Hi everyone, thank you so much for coming. My name is Nikki and I'm the Academic Engagement Commissioner in the Office of Academic Affairs at ASUCI. I'd just like to, before we begin, I'd just like to introduce Skylar Zhang, the Vice President of Academic Affairs, and Dill and Daniel, who are the commissioners for speakers and debate. So this event is a collaboration within the Office of Academic Affairs by Speakers and Debate and Academic Engagement. So Academic Engagement is a commission that seeks to host enrichment programs for students to engage with their faculty outside of the classroom. So we host various informal events and then some that are slightly more formal, such as this one. So we're hoping that from this event you'll be able to get a lot of your questions answered about the Affordable Care Act. And we also have a few other events coming up. So we have a workshop about the Big Bang Theory on next Thursday, February 20th, where professors will be explaining how scientific or not scientific the concepts in the show are. And we also have a speaker event with Cal Penn on March 5th. So thank you again for coming, and I'd just like to introduce our professors. So starting from the left, we have Professor Kanandale. He teaches in molecular biology and biochemistry in the School of Biological Sciences. He is originally from India and received his bachelor's at Bangalore University and his master's at MS University in India in biochemistry. He got his PhD at Rutgers University in 2006 in cell and developmental biology and started as professor at UCI in 2013. He currently teaches biochemistry, molecular biology, and various lab courses at UCI, and his primary research is in education. And next we have Professor Jafari. She's the Director of Pharmaceutical Sciences undergraduate program at UCI. She received her PharmD from UCSF in 1994 and did her residency at UCSF in 1995 in clinical pharmacy. She worked as a professor in the College of Pharmacy at Western University and worked to develop and direct the cholesterol clinical clinic at the UCI Medical Center. She also worked at Abbott Laboratories as a research scientist and joined UCI in 2005. She started the PharmSci undergraduate major in 2006 and has won many awards since then. She currently is a professor for pharmaceutical sciences and works with pharmacology in the School of Medicine and Ecology and Evolutionary Biology in the School of Biological Sciences. And she's currently teaching molecular pharmacology and does research in anti-aging. And then next we have Professor Blazer. He did his Bachelor of the Arts from Cornell University in Economics in 1974 and graduated Phi Beta Kappa. He got his Master's from Yale in 1975 in Economics and his PhD from Yale in 1978 in Economics. He's taught at Stanford, Carnegie Mellon, and UC Irvine. He began in 1979 and has been a full professor since 1988. He also was the director of Focused Research Program in Public Choice from 1989 to 1992, and the chair of the Department of Economics at UCI from 1995 to 1998. He's written countless books and journal articles and serves on the editorial board of many journals. And he also serves with the Institute of Transportation Studies. His major research focus is in political economics, but also has background in health economics. And he's not teaching any classes this quarter, but previously he has taught basic economics and health economics. And finally, all the way on the right, we have Professor Schoenfeld, who is a professor of political science in the School of Social Sciences. He also graduated Phi Beta Kappa from New York University in 1964 and got his PhD from Princeton University in 1970. He came to UCI in 1970 as an assistant professor of political science and was promoted to full professor in 1981. He actually served as the Dean of Social Sciences for 20 years, from 1982 to 2002, and has served under every chancellor in the history of the campus. He was the director for the Center of Study of Democracy and one of the 3 emeritus professors in the School of Social Sciences. He does research in authority, democratic theory, and comparative politics, and primarily in France. He teaches honors critical issues as part of the social sciences core for the campus-wide honors program. So please join me in giving a round of applause for Dr. So the format of the event is that we have a list of student-developed questions about the Affordable Care Act, which professors are welcome to answer in any order and say as much or as little as they would like about each topic. And as the event progresses, you guys can all feel free free to either email us more questions if you have them, or if you feel comfortable, just raise your hand and ask them. So without further ado, so the first question is, why is the Affordable Care Act important for students from your discipline to understand?
I can start. So how many pre-pharm and pre-med students do we have in this room? Raise your hand. Okay, so the rest of you are just interested, I guess, in the Affordable Care Act. So I will start by saying that if you read the Act, the two things that jump at you are prevention, preventive medicine, and also the fact that you're going to insure more people. So by the time that you guys start any type of education, let's say you're not going to medical school, you're not going to pharmacy school, you're going to study health policy or health economics. By the time that you start working, you're going to have millions and millions of more Americans who have insurance. And you're going to, as a healthcare provider, you have to deal with prevention and more insured people. And that's why it's important for pharmacy students and medical students to know. So I'm talking about my major because I represent pharmaceutical sciences. So no matter what field of healthcare you're going to choose, you have to start cultivating a wellness model of care and not a disease model, because that's what we have right now in this country. We approach patients as the symptoms that they have, and we try to treat the symptom. There is really not much going on right now when it comes to prevention. And with the Affordable Care Act, we are going to change that. The Act is also important for pharmaceutical sciences students because if you look at, so now we are talking about, let's say, 32 million Americans who are going to have insurance. These are the uninsured people who are going to be insured. And you're going to use drugs, right? So if you review the literature, you see data. Forbes published a few articles starting May of 2013 until December, talking about the role of pharmaceutical companies in this act. So imagine that these millions of people are going to be insured. What are they going to need? If you have asthma, you have hypertension, diabetes, and you didn't have insurance, all of a sudden you have it, and you come to me, and I'm your healthcare provider, I'm going to write a prescription. So it is estimated that pharmaceutical companies are going to have a net profit of anywhere from 10 to 35 billion dollars. So I don't want to go into details, but I highly recommend that you read the publications on the impact of the Affordable Care Act on pharmaceutical companies. Yes, they do have to pay Medicare rebates, which is, I don't know, $10 billion. They do have to pay back the excise taxes on branded drugs. They have to do all that, but at the end of the day, they're still left with a big profit. I really hope, and this goes back again to students in our major, I really hope that what we are projecting for the next decade, for the next 10 years, we are projecting that pharmaceutical companies are going to make anywhere from $10 to $35 billion, which is fine. But if we shift the focus again from a disease model to a wellness model, and the key is prevention, hopefully we are not going to write so many prescriptions on asthma medication, on diabetes medication, hypertension medication, and cholesterol medication, because we are shifting the care to a wellness model where patients don't need so many medications. So really the message that I have for our students is that you have to really educate yourself about the Affordable Care Act, because starting with your interview process, which is the beginning of why we should care, you're going to be faced with questions and issues that you really need to be aware of.
So I'll start with another question. How many of you saw me talking to, I guess, predominantly biomajors, and I don't know what biomajors do with their lives. So how many of you think you're going to be a patient at some, have already been a patient, or are going to be a patient at some point of time? So it doesn't matter pretty much what, and the rest of you think you're never going to see a doctor. Okay. So I think irrespective.
Because the rest of them are going to follow the prevention model. So
I thought we were going to solve the anti-aging problem. So I think irrespective of major, so there's certainly something to be said about from a career standpoint. Why is it important to know about the Affordable Health Care Act? But I think it's also important just as a citizen, irrespective of what your major is, as someone who's part of the society, to be aware of some of the groundbreaking sort of changes that we're undergoing as a society. And paying for healthcare is one of these things. And one of the largest things that the U.S. government, one of the largest spending that we have in this country is on healthcare. So how we decide to manage the economy as far as healthcare goes is going to have a huge impact on everybody, irrespective of whether you're thinking about from a career standpoint or from just a personal standpoint. So I think it's absolutely essential that you be aware of, what does this law mean, not only in terms of your career, but in terms of society, in terms of your future, and all of that stuff. So that's my take.
Well, I don't know anything about the Affordable Care Act. I'm much like you. And I certainly don't know anything about what it's going to be like. But then again, no one else does. What we're filled with is projections and pronouncements by people who claim to be extremely knowledgeable about what's happened so far and what will happen. So, for instance, just this weekend, Mr. Durbin, one of the leaders of the Senate, for the Democrats, announced that 10 million people have signed up for the Affordable Care Act. And the one thing we know is that's a big fat lie. We don't quite know how many have signed up for it. The data is very incomplete. We think maybe around 3 million people. Mind you, out of a population in the country that exceeds 300 million, it's not, we don't quite know what this thing is going to mean. And one possibility is that the political environment gives rise to a de facto end of the Affordable Health Care Act. It's very likely that in the forthcoming Congress, Republicans will have a majority in both the House and the Senate, undoing Obamacare as a central agenda item for them. And if they win the presidency the next time around, then who knows, they might actually do what they said they were going to do. But let's say they don't do that. What we know is the country is already going broke trying to handle Social Security and Medicare, which guarantees that all of you are going to have to work a lot harder than all of us, and a lot longer because you've got to take care of us. I mean, most health care costs arrive at the end of one's life, not at your time. So I'm delighted with all these policies. They're going to be very helpful. And you're probably going to be working much longer and much harder than I ever have to pay for my health care, which is getting more and more expensive, in part because of the drug companies, but also because of technology. The problem that has to be addressed here, and it's a complicated one, is that we can legitimately say everyone deserves health care in our society. I certainly believe that. I also believe everybody deserves higher education. Now, it used to be in the state of California that effectively higher education was free of charge for students. At the University of California, at the state colleges, and at the community college. It no longer is because the society can't pay for it. The central problem, in my opinion, of the Affordable Care Act is, can we pay for it? And if we can pay for it, what else are we not going to pay for? And no one has a good answer to that because we don't even know how many people are signed up for it. We know nothing. We have the president making announcements. If you like your health care, you can keep it. He said that doesn't it? If you like your health care, you can keep it. This reform will do nothing. Lie, lie, lie. We don't know. We have politicians on both sides making arguments according to their policy preferences. But we don't have the vaguest idea what's going on here. We do know that in societies like ours in Western Europe, countries are having an ever greater problem to fund their equivalent of health care for everyone, along with Social Security and Medicare. So there's no reason to assume we can get away with that, unless some crazy miracle happens, and I don't believe in crazy miracles. So to me, the issue you have to think about, and there's nothing whatsoever to do whether you're going to be a pharmacist, an MD, or a care driver, is the fact that you want something. Is that important? Certainly it is. But is it also important, can you afford it? And how can you figure out what you can afford as an individual and as a collective?
No, I can do that. I'm happy to do the next question.
Okay.
What to say.
So the next question is, what implications do the policies of the Affordable Care Act have on us as young Americans rather than as students?
Well, first let me tell you the bad news. You will die. The question is when.
That may not be such bad news.
So let me give you some data. In the U.S. as a whole, out of 100,000 people, about 800 die each year. And the biggest cause is about a fourth of the people who die in the country as a whole died from heart attacks, heart disease. 200 per 100,000. Next big cause, and almost the same, is cancer. Third is cerebrovascular diseases, strokes. So these are all health things. That's what people are dying from. Next comes chronic lower respiratory diseases, things like emphysema from smoking. After that comes accidents, which is only about 1/20 of all the deaths. After that comes diabetes, then influenza, then kidney disease, and then infections of the blood. So that's on average in the country how people die. Let me tell you about you. So the data are, it's broken up in different age groups. You're between 15 and 24 years old. Number one, your death rate is 80 per 100,000, a tenth of the general population. So the good news is you're not dying soon. But what will you die from? The biggest cause of death for people of your age, and that's over half of the people who die in your age, is from accidents. The second biggest cause is murder. The third biggest cause is suicide. The fourth, notice none of them are medical. The fourth is cancer, and that's only 1/10 of the people of your age who die from cancer. And remember, you're not dying. You only have 80 per 100,000. So in terms of health, medical care is irrelevant for you at your age. So it will not affect your health. It may affect other things. There are a few things with accidents, but it will not affect your health because, boy, are you healthy. The one thing you should do, and this is data, about protecting your health in the future, one of the striking things about the U.S. is we have really miserable health outcomes. So compared to other countries, we spend much more, and we have higher death rates, we live shorter, we have higher infant mortality. We do miserably compared to any other rich country. And the main cause appears to be cigarette smoking in the past. So it takes about 20 years for cigarette smokers to have an impact. So my bottom line is, don't worry about your health care now, and B, don't smoke.
I actually like to ask you a question. So if I'm not talking about this room, I'm talking about the country. And my students ask me, where can we go to see a sample of this country? I say, go to Disneyland. Go to Disneyland because you have the sample population of this country there. If these kids, if your age group, and I'm assuming this is 18 to 25, if they don't have to worry about their care right now, why do we have such an epidemic of obesity among young kids? I mean, 2 out of 3 now, overweight or obese. And I can also go back to kids, not just young adults like you guys, children. So yes, you may be very healthy right now, and if you're not a smoker, the chances of you dying or having a medical problem is very low. But if we continue the practices that we have right now, we are going to get there. And that's why this country has an epidemic of diabetes and obesity.
If I can, so the National Research Council, which is a federal organization, actually private, funded by the government, it commissioned a study why death rates in the U.S. are worse than in Europe. or other rich countries. So Japan is even better. And it's not only that we're worse, we're getting worse compared to other countries. So life expectancy is increasing more in France than it is increasing in the US. And they asked why, and the one thing they identified is smoking by women about 20 years old. They addressed the question of obesity. And we don't know anything, but they didn't provide evidence. So they said, we don't have evidence that obesity is the reason for higher mortality in the US.
To answer the question, why do we tend to be obese, which I think is a very important question, is because we eat too much.
Yeah, I don't know why the fancy report didn't have an answer. We eat too much, and we eat the bad food. That's why you're getting obese.
The evidence isn't there that diet creates bad health. Not there.
So I just noticed that we were talking that we actually lined up according to age. So that side's all the pessimists.
Incidentally, I was 20 years in administrator. I am 31. How old are you? I guess according to age.
Then I'm 10.
So there are other people worried about you're dying. So I play a lot of volleyball. I'm not dead, but I racked up quite a big medical bill when I tore my ACL. So I don't think Medicare, or I'm sorry, not Medicare, but health insurance, I don't think has to do with just people dying. I think you can be young and you can be active and you can still need to go to the hospital and you can still need fairly expensive things done to you that have nothing to do with dying. So how you pay for it, as was the question that was raised, is going to be important. Especially if you're a student at UCI, you're working a job just to put yourself through college, and now suddenly you've torn your ACL because you were playing soccer and the idiot goalie stepped on your foot while you were going to score a goal. You're playing football, whatever it is, right? You're going to injure yourself because we're all active. These old people are worried about dying. So I think it's an important thing to know. How are you going to pay for it? What's your? I mean, many of you are going to be on your parents' insurance, but someone has to pay for it.
Can I say that I agree with you 100%? I think what you said is eminently reasonable. It's my understanding that in the United States today, 75 to 80% of our expenditures for health care are occurred during the last 6 months of life. So what's costing the money is not to take care of you, it's not even to take care of me. It's to take care of the people, even older, hard as that might be to imagine, and even less vigorous than I am, because I'll probably doze off in about 15 minutes. Because, I'm not young and agile like my colleagues are.
I'd like to add something. Just this is a fact check. So before Affordable Care Act, when you turn 19, you had to have your own insurance because you could not be under your parents. But based on ACA, for most states and most situations, most of the country, based on Affordable Care Act, now it's 26. And I think 26 is a great age because by that time you're done with undergrad, hopefully you've done some graduate school working. If you're going to any medical school or pharmacy school, again, I'm talking about just our major, you have finished those graduate programs too. So you're starting a residency and you're going to have an insurance. And to answer your question that yes, you're spending majority of the healthcare expenses during the last year or 2 years of our lives. Why? Because we have chronic diseases. So we have diseases of aging. And I'm not going to talk about my research, I promise you. So how could we prevent that? By preventive medicine and by allowing people with pre-existing conditions, as outlined in the Act, to have insurance. Because by doing that, okay, so you guys, I won't see the long-term effects of Affordable Care Act, but you will. Because if we do it right, I'm not saying that this the implementation is going to be as great as the Act is written, because I am going to raise my hand and tell you that I'm a big fan of Affordable Care Act. But the document is not implemented yet. We have problems. The website was, acting up. We don't know how many people are insured. I get it. I understand that we have lots of issues to fix and fine tune. But the act as it is written, it was needed, it was about time to have it in this country, and I think this is something as future healthcare providers or scientists or biologists to be excited about. So the keys to start here, which is the prevention, and hopefully in 20, 30, 40 years from now, we see the benefits.
Can I make one observation and bring in one historical fact? I agree with you. One of the big problems with the Affordable Health Care Act was the following. Big issues of that sort, as society confronts them, need to be consensual decisions. When Medicare was introduced, Lyndon Baines Johnson was president of the United States. He was a Democrat. And the Democrat majority in the Senate, they had 70 senators. So there was no need for the Democrats to even talk to the Republicans. Johnson left the White House and went to the Senate office building to meet on a set of occasions with Senator Everett Dirksen, the Republican minority leader of the Senate, who had no political power, to get his and the Republicans' basic agreement that we should have Medicare. And he achieved that goal. The result was that Medicare was largely a consensually implemented policy across the political spectrum. In contrast, that did not occur with the Affordable Care Act. A decision was made by a majority, and mind you, in a very tenuous majority, in a very peculiar way, without political legitimacy, to push through a position that they believed was right. That's a problem. Big issues of this sort in a society require the wisdom of the collective political class to go along with it. The way the Affordable Care Act was implemented, in my opinion, runs the substantial risk of it not being implemented the way you might want to.
But it's not implemented yet.
Well, of course, but we don't know the way it will be. We don't even know if it will be. And part of the reason is because not arrived at consensually, big problems in a society, in a democratic society, must go across the political spectrum. When in France, they legitimized abortion to be paid for by the healthcare system, it was on a vote that brought together the left and the right. Why? Because it was the belief of politicians on both sides that such an issue cannot be a political divide issue. It has to be something that's supported by the whole society. In our case, we never even voted on it. It was a court decision outside of the democratic process. The Affordable Care Act, I fear, will have long-term problems in implementation because it was not put in properly.
So, sorry, I'm going to stop you here for just a minute and backtrack and see how many of you know what the major points of the Affordable Care Act are? Do you know what changes that the Act actually makes before we have this wonderful debate? Okay, so that's maybe just a handful, right? So, are people just afraid to raise their hands? No, so it really is just a handful. So maybe we should tell them what are some of the changes
The
they're
top
going to
5
have.
things you need to know for.
So I'm going with no pre-existing condition. So traditionally what's been happening is you go in, if you have a pre-existing condition, sometimes I had a friend who was denied insurance because her pregnancy was a pre-existing condition. So things like that no longer can happen. You cannot be denied insurance coverage based on pre-existing condition. That's my number one.
Number 2, and this is my number 1, but it's the number 2 tonight. Prevention. So the government is spending a lot of money on preventive medicine. meaning that if you are going to see your doctor, and I'm going to simplify it, if you're going to see your doctor, they are going to do some screening tests. I mean, you guys are too young to have cancer diagnostics. But pretty much anything that would prevent a future disease, even checking cholesterol, checking your glucose numbers, those are going to be free. And it doesn't matter at what level of insurance or what kind of insurance you choose in the marketplace, preventive medicine is going to be included no matter what your insurance is. My own criticism to this issue is that, okay, this is great. You're going to train more primary care providers. You're going to spend, the government is going to spend millions of dollars to train primary care physicians. So if you guys are going to medical school and you decide to become a primary care physician, if this act continues and gets implemented, you will have a job. My problem is that with this act, we have to backtrack and start educating our students. We don't see any money for education. How can these physicians become great wellness model doctors if you are not educating them? In our medical school at UCI and all other medical schools across the country, how much time do we spend teaching our students to take care of themselves, their own health, and also preventive measures? Not much. So that was my number 2. You had your hand.
I was curious, does that include MRI or CAT scans or just glucose or blood sugar levels?
I'm sorry?
Does that preventive checks, does that include MRI and CAT scans?
You know what? I knew you would ask this question tonight. The answer to this question is that the immediate answer is that I don't know, but if you read the fine print, it depends on your medical history. If you are in a family with a strong history of cancer, let's say I'm a 30-year-old woman and I'm not supposed to get a mammogram, but my mother and my grandmother and my aunt, they died in their 20s and 30s due to breast cancer. So that may qualify me. But I don't know the answer to the question. The immediate answer is probably not, because those tests are very expensive.
Let me do number 3. The individual mandate. You have to buy health insurance, or you have to pay a tax if you don't. There's also an employer mandate, but let's do the individual mandate, which that can affect you the most. Well, if health insurance is so good, why are you forced to buy it? And the answer is, you have to buy it, you know, 18, 24, like, because you're really cheap to insure. You don't have medical expenses, but you have to pay a high premium, and that's going to pay to cover me. So I really appreciate it. But that's an essential element of the individual mandate, that the young have to buy insurance to subsidize the non-young.
I have a question about that. So this thing where you can stay on your parents until you're 26, doesn't that kind of defeat the purpose of what you just said?
No, it forces you to buy insurance. Because my premium, so my daughter is not yet 26, she's on my insurance policy, but I pay more insurance.
So you're not paying, your parents are paying.
I'm paying.
So someone's paying.
Usually someone is paying.
Okay.
So the idea is that young people have to buy insurance in one way or another. Because you're really cheap.
Question, Jafari?
Are you sleeping already?
You know, at my age, it's a miracle that I'm sitting on, usually lie down at 3 in the afternoon. I like your question about paying house scales, etc. Because I think one of the reasons American medical costs are so high, and one thing that the Affordable Care Act does not do at all, at first, but might, through its implementation over time, is change the culture of expectations amongst Americans when they go for health care treatment. Americans look at health care as though it were something different than everything else. It is to be provided equitably to everyone, no matter how little or how much money they have. Everyone deserves the first line health care. What does that mean? They deserve all the scans they need. They deserve all of the chemotherapy they need. They deserve heart transplants, open heart surgery, whatever it might be. These things should not be, according to the American culture, in any way differentiated according to your wealth. Now, when we hit a purely private-oriented insurance, effectively individuals, and most importantly, because most Americans were not individually insured, they were insured by their companies. I mean, the four of us all had health insurance. None of us ever went out shopping for it. The University of California provided us with a set of alternatives, and we chose option A, B, C, and D. We might pay a little more or a little less and get a little more coverage or a little less coverage. A lot of that's ignorance and the Affordable Care Act. But the baseline problem that we face is now we're going to have a national system. And a national system cannot afford for all of us to be having all of these tests, which are unbelievably expensive. Now, for instance, at my age, one test that everybody starts having every 5 years is a colonoscopy. This is a test, for those of you who don't know, in which a stranger takes a tube and puts it inside of you from the bottom up. And if you're really lucky, at the same time they do an endoscopy with a tube down, and two tubes meet in the middle and shake hands. Now, I've never met anyone who wants this test. Oh, please give me one surgery without anesthesia. It is not a soft medical technique, but at this stage, once you hit a certain age, everyone's supposed to get them to reduce colon cancer. Well, now you start having everyone insured and doing this. How are you going to manage all that? And I think one of the things that's likely to happen over the long term is that we have to, assuming it sticks, we have to change our culture. And we have to understand that not all of these things can be provided for. Because we just don't have the money to do it. I mean, a colonoscopy, I don't know whether it runs $10,000, $15,000 a pop. I mean, just think about that. The billions and billions of dollars, the number of hours each of you are going to have to work so that somebody can put a tube inside of me. I mean, how terrible. So the culture of what our expectations are for medical care is different than in many other countries, and one of the reasons it costs so much.
You know, the cost of a colonoscopy is less than $2,000. Let's say you don't have insurance and you're paying out of it. But the thing is that if I diagnose you, if I find polyps, if I find early cancer, and I treat it right away, you're not going to be paying about $25,000 to $30,000 worth of chemotherapy, surgery, hospitalization, pain management, and you name it.
Do you believe UCIMC charges $2,000 for colonoscopy?
I think it's, at UCIMC is about $900.
Okay. I'm going to get my bill and I'll send you a copy.
Okay.
May I ask you the following? Will you give me a nickel for every dollar it is above $900?
No, because you know what, let me tell you, I won't do that because it's another problem in this country that I don't think it's Affordable Care Act. It's just the data becoming public. So until recently, if you wanted to compare how much Coke charges for a colonoscopy compared to UCI, compared to Irvine, the Irvine Medical Center, you didn't have that information. It was all secret. But right now, you can, because our government made this mandated that they have to be public. The information has to be public. So yes, I agree with you, and that's why I'm not going to give you a nickel, because I don't know exactly how much.
Nickel on the card.
Yeah, no, that's too much. I
I'll
mean,
give you for every dollar that is on
I
the
may
dime.
have insurance, but I'm a UCI professor and I don't make too much money. So this is another exciting news, that this information is public, but it wasn't before.
Let me address the issue, does medical care improve health? And the answer is overall no. The U.S. spends 17% of everything we produce on medical care. So about 1/6 of every dollar that we produce in the country goes to medical care. Most of Europe is about half of that. And their health is better. So that's one data. But we have even better data from two sources. One is called the grant health insurance experiment, where essentially some people were offered full health insurance and other people were not. And then there were tests of their health. So actual measurements of blood pressure and other things. And it turns out that people who had health insurance, generous health insurance, spent about a third more on health. So they said insurance company. So spending on healthcare is about a third more when you have full insurance coverage than when you don't have insurance. But the measured health outcomes, with 2 exceptions, having to do with high blood pressure and vision, no difference. So big increase in health use, almost no difference, or no difference except for 2 things in health. That was one study. There was another study done in Oregon, which was recently got lots of publicity. And there was a lottery in Oregon for Medicaid. Oregon didn't have enough money to fund everyone who wanted it, so they had a lottery. And some people won the lottery and some people didn't. So you can compare the people who won the lottery and got free health care to those who didn't. Health spending increased by about 30%. Same as the RAND study, although it was done differently. Emergency room use increased. So the idea that preventive health care, health insurance, you see your primary physician, you won't go to the emergency room, that's not true. Health outcomes were essentially the same. And even for things like diabetes. So people, these were unhealthy people. These are very poor people. They were unhealthy. They wanted the health insurance. So they got drugs for diabetes. And then the researchers measured the sugar levels to see if the drugs worked. They didn't. No improvement. The most surprising one is cardiovascular disease. Now, they couldn't do it directly because the number of people with heart attacks in this population was small, but you can have some measures. Diseases of the heart increased among those people who had health insurance. And you wonder why? They were worrying about losing it. Actually, there was less stress, so you're right. The reason is because you have to be an economist to know the answer. People who had health insurance started smoking more, perhaps because they thought, if I smoke and I get ill, then I'll have health insurance, so it's not that tragic if I smoke. And to increase smoking more than overcame any health benefits. So even if you can give 100 examples that medical care saves people's lives, that does not mean that when you provide people with health insurance, they will be healthier. Because we have data from the Grant Health experiment, we have data from the Oregon experiment. It increases spending, it does not improve health.
Hello, Roger. Earlier you had mentioned that obesity had no effects on health. And I have to say, I have to disagree with that. The reason being is currently I'm interning at St. Jude's, and we're working on prevention programs for kids. The main problem they're having is, what they're looking at right now is, the problem is with smoking in the beginning, everyone was like, well, we don't think that it's a big deal, it's sentencing, later on we find out it is. And it's kind of what's starting to happen now. A lot of hospitals are really opening up to the idea of, wow, obesity is causing a lot of problems, causing a lot of diabetes, it's causing a lot of different diseases that are really costing a lot of money. And the reality is part of that problem is unfortunately healthcare really can't help. And that's that there are so many fast food places in low-income areas. I was from a low-income area. You can go to a fast food place anywhere you want, practically any time. And you're filling yourself up with that kind of stuff, it's so cheap. The reality is your body's not going to function the same way as someone who's getting really great produce and things like that. I'm from a different part of San Diego. You can see differences in children's population, how they're reacting and everything. And I think really in the future, we will see a big impact from obesity. So I do have to disagree with you on that. I think you really have to prevent the obesity epidemic before it becomes a huge medical cost.
I'd like to add to what Brandon said, that I agree with the data that you presented, but that's why I said education is the first step. So yes, you can insure everybody, you can increase the number of your primary care physicians in this country as it's going to happen in 2015 by 2,000 more. They said 1,700 more primary care physicians. But if you are not doing a good job educating the public and those primary care physicians, what is going to happen? And the education starts here at undergrad level, not even a graduate level.
The second professor was saying that there were the 2 studies he was saying that they people actually caught this or something like that.
I'm sorry, heart disease.
I've had 3 heart surgeries, and the first one I was one, I get it on this line in 5 years or so. It wasn't for like Medicare insurance. I would have 7 years or something. So like, to generalize
So let me just say, absolutely, we can come up with hundreds of thousands of examples of people who are alive today who would be dead if they didn't get medical care. But that's not the question. The question is, if we change the system, provide health insurance or increase the number of hospitals, will that increase medical care? And let me give a reason why the two are very different. One example is mammograms. And there was another study by the National Research Council, so they're really good. This is, I mean, it's not partisan, all means they take both sides. These are real researchers. These are the top people in their fields. It turns out with mammograms that they will detect some women who have breast cancer, and if they are treated, they will live, and we can hear stories of those people. That is true. But what we don't hear about is those women who have a mammogram. They get false positives. That is, the study says you may have breast cancer. They don't. They undergo biopsies. They go to the hospital. They have surgery when they didn't need it. They may die from the anesthesiology. They may die from the infections. So we can't just look at those people whose lives were saved by a particular medical procedure. There are, of course, hundreds of thousands of millions of those. We have to look at what happens in the whole system, and we don't hear of the stories of the woman who was told she has breast cancer, and she didn't. It was false. And then she got into a depression, and when she was driving home, she died. We don't hear of them. So you have to look at the aggregate statistics. And the aggregate statistics show, mammograms is one of them, under age, I think, 65 or 60. It's no longer recommended. So both Republicans and Democrats say, get it. The aggregate data show that, in general, increased spending on medical care does not improve health. There are some exceptions. Absolutely, this isn't always true. But overall, it is wrong to believe if we spend more money, if people have more health insurance, they'll be healthier.
So in terms of logistics, do you think that Obamacare can be implemented the way it is right now and succeed in helping balance the cost with profits? Because from what I've read online, if you don't pay the $300 a month that it requires, you just get a fine at the end of the year for $95. And in terms of cost, I think a lot of people would prefer the $95 in terms
which the IRS has no way of enforcing it. They say you have to pay, but if you don't pay, nothing happens to you. It's weird.
So
I just want to go back to something that you guys are probably sick and tired of me saying that. I just want to go back to the education. So my answer to your question is that no, this act is not going to be successful unless we start dealing with the basis. And my question to you is that if what you're saying is true, why in many European countries where they tax people if they're overweight, if they smoke, if they're this, why do they have better outcomes? So yes, I can look at this country, and I'm going to tell you that we don't do a good job here because the education is lacking. In those countries, they start the education from the start. And if preventive care was not going to result in great medical outcomes, why do we have all this data? I mean, we have basic science data suggesting that when you start prevention at a very early age and take care of yourself, you're going to have a healthier life when you reach old age, and the last 6 months and the last 2 years of your life are not going to be as costly. I mean, we do have that data too. So it's like yes, you can present all the data, but then I have, for every study that you are presenting, I can talk about other studies that were done in other countries. Because those countries, the focus is on education.
So the National Research Council, one of the studies I'm referring to, looked across countries. So it didn't just do the U.S. It asked, why is the death rate in the U.S. higher than in any other, essentially, rich country? So they did look at it. And the main reason they came up with, and I'd say essentially the only cause they came up with, was 20 years ago, Americans, particularly American women, had much higher cigarette smoking rates than European women. That is no longer true. It may be that in 20 years from now that Americans will have higher life expectancy than Europeans because our smoking rates have plummeted, particularly in California. Cigarette smoking, a huge success, huge public health success. But that's what the data find. And this was a data which surveyed lots of other data, so it's not one person doing his own studies. It was a survey aggregating lots and lots of studies, and cigarette smoking, especially among women, was the primary cause.
officer. May I suggest a way of sort of putting together your two views? Your view is it was cigarette smoking 20 years ago, which causes the American worst case. And your view is we need to get involved in prevention, particularly to reduce obesity. Now, it ends up that on the whole, when people smoke, they eat less. And it may be, and I don't say that that's a joke, but it may be that as people stop smoking in this country, there's a correlation between the reduction in smoking and the growth in obesity.
No, we are more obese because of what Brandon just said. Because
Well, there are fast food places everywhere in the industrialized world. I mean, Burger
But
King
you're
is an
making those
English outfit.
But look what's happening in China. Chinese were not overweight and obese. They are becoming overweight and obese because KFC, McDonald's, and all these other fast food restaurants are
because they're
opening.
beyond the subsistence diet, which may contribute also to weight gain. I mean, it may be a function of acquiring wealth. And also, you were right here that certainly France does not sanction people for smoking or for being obese. I mean, I don't know what the European country does.
Scandinavian countries. Norway is probably one of them, and I can't think of others.
Okay, but certainly France, Germany, and England, you know, big economic countries of Western Europe do not do that.
But France has a socialized system. I mean, I lived in France for 4 years. I know the medical system in France really, really well. Health insurance for everybody. I mean, I was a high school student. My parents were immigrants. They didn't have insurance. I had insurance. I got the best dental care and the best medical care during my 4 years of high school. With just arriving in the country. The moment I arrived, the next day I had medical insurance. Do we have that here? No, we don't.
No, and the Affordable Care Act won't give it to us.
If it's implemented,
No, it won't. Definitely not. It's very different. There's a single provider system. Ours is a system which is organized around states.
Yes.
And it's a very, very different system. If totally implemented in the best possible way, it doesn't come close to the French system. That's a fact. Because
we are a different society. We are not the
Swiss have a different system. It's not just different. It's because of a lack of political vision on the part of Obama to bring together a consensus. It's a policy designed to aggrandize a particular political leader rather than resolve the social problem.
Yes. Wouldn't you say it's important to start with the Affordable Care Act in hopes of achieving a system like France's, for example?
I think it would have been much better if we could have started with a centrally arrived definition, which I think under certain circumstances was possible. That is to say, if you brought together most reasonable people, let's go before the Affordable Care Act, and if you said, is the health system in the United States working well, there would be a chorus of no, it is not working well. Some of the reasons that were mentioned would be kicked off, but other reasons also, the extent to which there are lawsuits on our healthcare system. The spiraling costs that have grown at an ever more rapid rate. And if you begin with that element of discussion and then you try to make pieces of resolving the problem, I think we might be 5 years from now in a better situation than we actually will be in 5 years. I'm a big believer that while a democratic system does involve majority rule, the majority cannot ram down the throats of the minority something they don't want. A democratic system for big issues requires consensus politics. And if you don't have consensus politics over big issues, you continue to create a political undercurrent which will vitiate the policy. That's my bottom line concern. I certainly would not want to justify, I agree with you on the French system. A single provider, a wonderful system, controls over what you can get and what you can't get. Very different culture of what would be offered. I mean, I'll give you an anecdote. No, I won't give you. Shut up. If I can answer this.
So can I say, so I think, so what I'm hearing about this discussion, there's sort of one major issue that I'm seeing. The U.S. system, if you have healthcare, works great.
No.
Yes, it does. I have healthcare,
No, it
it
does
works great. When I tore my ACL, my out-of-pocket expenses were about $150 grand total. So it worked. The problem is, what are you doing with those 40 to 50 million people who don't have health insurance? And that's one of the big problems that the Affordable Health Care Act is trying to deal with, right? So that's sort of the thing. If you have health insurance, you're good. It works. For the most part, it works really well, right? The problem is you have about 40 to 50 million people. I don't know what health insurance you have. All of the health insurance I've had, starting from graduate student health insurance that worked well, all the way to UCI health insurance that works really well. So I don't know. Maybe you have a different health insurance. But the problem is, what are these 54 million people that don't have health insurance? Are there ways that we can spend, and sure, once we have the money, are there ways we can spend the money better? Probably. But you still need ways to pay for the health care that those 54 million people need. And that's the big issue that we're trying to deal with this Affordable Health Care Act. The analogy, sorry, I'll get your questions. But the analogy I think of, from my perspective, is forcing everyone to get automobile insurance doesn't decrease the number of accidents on the road, right? But what it does is it helps sort of allay some of those costs that are going to be generated when you do have these accidents. And that's sort of the analogy I like to think about when I think of the Affordable Health Care Act. You may be absolutely correct. I don't know. There's probably plenty of studies that would say one thing or the other. And maybe increased healthcare spending doesn't equate to better health. I can tell you, coming from India, the health system sucks there, and it's terrible. So I would agree that spending some money on healthcare is probably not a bad idea. But again, the problem is, what about those 40 to 50 million people, depending on whose numbers you look at, who have absolutely no health insurance? That's the issue, I think, that we need to, that we're trying to address.
If I may, just two issues quickly. Number one, Number one, health insurance is not the same as health care. I care about people's health, not as much about health finance. And you can have health insurance and not get health care. And we're getting it in California. People bought insurance that covered California, and they can't find a physician in their network. So you can have health insurance without getting health care. You can get health care without getting health insurance. UCI Medical Center treats thousands of people without any health insurance. So the general taxpayer. So those two are separate things. The U.S. healthcare system is bad not only for the poor. So if you compare, I don't remember the exact numbers, but something like the top 1/4 of Americans, the wealthiest, compare them to the bottom 1/4 of people in England. Outcomes for the bottom 1/4 in England are better than the top people in the U.S. So it's not that wealthy Americans are getting great health care. The one exception is over age 75 in the U.S. does better. It's not in general true that it's all money.
And there was a question or a comment.
Oh, I'm sorry, just one more. The uninsured, you know who they are? You. Overwhelmingly, these young people. You may need catastrophic health insurance, but you don't need colonoscopy coverage. So yes, there are millions of people who are uninsured, but overwhelmingly there are people who don't need it because it's you.
What was the number three?
No,
wait. What was the number 3 on your list for the suicide? Who do you think commits suicide? What do you guys think is the ideology for suicide?
Bad professors.
Why? All you 160 students.
But why do you think that? And this is true. It's a very, very sad reality. Suicide is number 3. But who commits suicide? Depressed people. What is depression? It's a mental health problem. And with the Affordable Care Act, one of the top priorities is to start spending more money in schools and colleges when it comes to mental health.
Just sell them all guns.
Oh yeah, that's so we can't say that the young people in this country are dying for non-medical related issues. If suicide is number 3, that is a very, very important medical issue. It's the depression. I have students in my office every week who use me as a therapist, and I said, listen guys, I'm not a therapist, I will help you, and I call the behavioral health clinic here, and when do you think they give them an appointment? 3 months. I said, no, you can't do that. My student is suicidal or whatever. I have to sometimes exaggerate over the phone. And then they said 3 months. I said, no, you can't. So I walked with my student to that center, and they still say 3 months. So if you don't have insurance, you have to stay in line for that 3 months, and I don't know what's going to happen to you from now until the 3 months that you get that appointment. But if you have insurance, you can go see a provider and hopefully eliminate number 3, the suicide on that list. Okay, so this is a conspiracy. Question.
So, thank you so much.
Appreciate it. Mr. Schoenfeld, about consensus politics, I think that would have been ideal. Having some sort of consensual outcome, and the Republicans also hoping it's not just the Democrats that have passed this. But I just, from my memory, my recollection of when that bill was being passed, that could just never have happened for the very fact that what Obamacare is, it's a conservative reform. Had it been a liberal reform, it would have been something single payer. And many of his ideas had been what Mitt Romney, a governor, Republican, had been doing, what the Heritage Foundation had been proposing in the 90s. So these were conservative ideas. The individual mandate was a conservative opinion. And they were now backing away from that very option.
He's going to beat you up, right?
I'm gonna kill him.
That was number 1.
Remember, I did make from going to the office of Everett Dirksen to negotiate the specifics of Medicare. Obama became president in January. The first face-to-face meeting that he ever had, alone with Mitch McConnell, the first was 10 months later. He didn't bother to talk to the man. Well, politics, a lot of politics has to do with people getting to know other people and getting to work. Obama, in part because there's a lack of political experience, rather than going out and working with people who knew he won the election and probably might have negotiated, what he did was he snubbed them, making them angry with him. And in turn, he angry with them. It is a lesson. It's hard for us to accept, because this is happening in our time. But as historians look back, they will discover that the central problem of Obama in governance was his failure to work with other people when he had power, as if he was just the other guy in the room. That's what Johnson was saying. So I disagree. I think it was.
But isn't that the case with all U.S. presidents? Because I'm trying to think that when we went to war, did the entire country vote on that?
The majority of Democrats supported the Iraq war with Bush. The majority of Democrats supported the majority of Democrats. Bush worked with the Democrats to get them to support our invasion of Iraq, as insane as it was. The majority of Democrats voted for it.
Was it before the UN report or after?
You'll get your heart transplant.
No. The reality is that Bush did it, Reagan did it, Clinton did it, Obama didn't do it. It's very simple. It doesn't matter if they were Democrats or Republicans. It was if they were clever or stupid.
So, when Medicare and the Medicare report passed, my recollection of the election, it passed the U.S. Senate 81 votes with the vast majority of the Republicans. So you're saying that, and that the war, so when Medicare passed in years, passed the U.S. Senate by 1 vote.
Right, there was a lot of Democrats.
It was the first started as a consensus.
Right. But remember, Bush was a Republican.
Yes, but he still ran the House and the Senate. So you're seeing that.
Getting the support of Democrats. Not a single Republican
And then when it was 2009, it happened to communities and law,
Yeah.
then they obviously president, he wanted no, Mark Office. He had a lot of hearings and hearing those laws. Good, really, they were so against
But again, if you probably, if you make a decision, and then you say people explain, and if you haven't worked with them.
Actually, the old doctor over there.
Okay, back to healthcare. Okay. So anyway, the biggest concern I have, and I think everyone kind of agrees this, we all are worried about this reality is after college, we go back to where we work. Right? Well, the biggest concern I have is I'm a corporation, it's a corporation, and it's self-passed. Now, I still just go out to pay, not pay a little more per employee, but I get a tax credit by putting jobs overseas. So why am I, as an employer, in my right mind, going to hire someone here when I can go over there, not only pay less, I get a tax credit for doing it. Now, see, the problem I have with this bill is how come they didn't incorporate too by saying, well, why don't we give tax credit for companies hiring Americans and actually increase taxes going abroad? So how do people alleviate the cost for businesses to hire Americans? And I know everyone says, yeah, the reality is I'm a business, why am I going to hire an American when I can do something else somewhere else?
Just move to India.
I mean, it's serious. That's what I'm asking now.
I think it just goes back, I know you guys are just covering your ears now. It's about education. It's about educating people. It goes back to it. Because if you're an educated person and you really care about this country, you're not going to buy something that is 99 cents because you want to save 50 cents. This is what I think. And I try to really live my life with what I'm saying. I mean, some of my students are here, they know how I am. Okay, is this made in America? Really made in USA? And then, then we can talk. So it's all about education.
Was there another question over here?
It's more of a comment than anything else, but I think that we've been talking a lot about the toxic political atmosphere these days and how polarized it is. And I don't think that we can really trust politicians anymore to do what's in our interest because they will only do what's in their interest.
Can we just start what we can't trust politicians. I mean, this.
Yeah, and they will only do what they need to do to get reelected, which is, they'll switch sides as fast as they can in order to get what they want, or to just stick with, their party. So what do you think that we can do as students to...
Vote. Let your voice be heard. Because that's the lowest voting demographic. Like seriously, there's like old people who you're all paying for go and they turn out they're like 80% of the old people go vote. Like 30% of the young people go vote.
But I think the problem with my generation right now is that we're all very disillusioned because we've seen how bad it's gone.
But the only way you're going to change that is by voting. We live in a democratic system. There is no other answer. There is nothing else you can do. I mean, sure, you can throw car bombs or whatever, but that's, France tried that and didn't really work. So, that it is, change is going to come slowly, but you go out there, you make your voice heard, you campaign, you go vote, you make sure every single person votes, and that's how you bring about change. A classic example I want to give you is, there was, I believe, the state sitting senator in Colorado. So Colorado recently passed a law that said, we're going to increase background checks for people buying guns, right? Perfectly reasonable law. They didn't say we're not going to let you buy guns. They just said we're going to make sure you're not depressed and not a student and not before you buy a gun, right? 80% of Colorado's population agreed with that law. 80%. The senator got recalled in a recall election because those 80% that supported him didn't even know it was a recall election, didn't vote for him. The 20% of the crazy people that said the government can't tell me what I can buy a gun or not, went and voted. Right? So this is the problem. It's civic engagement. There is nothing else there's no magic pill that you're going to swallow and suddenly politicians are going to be great. Right? There's no magic pill you can make politicians swallow and make them be great. So, what you want to do is, and there's no educating them because they're too old. So, you So that's what you do. You change the electorate. You say this is what we want, and then if they have to get re-elected, they got to do what you want.
But it just seems like whatever we do, change isn't going to come for another like 5, 10, 20 years, because in terms of changing the way that we educate these younger people, and in terms of even educating them about prevention and health issues, I would say that it would only occur and make a big difference like 10 or 20 years from now. So for now,
but that's still in your lifetime. That's still you and your kids. Is that not worth trying? I mean, don't just shrug your shoulders and give up and say, oh, I'm not going to see it for 10 years. Right? This is the other problem I say, is that we're all worried about today, and you don't think long term, which is kind of silly, right? Because, again, sort of the example I like to give is, everybody knows we're going to run out of fossil fuels, right? There's no arguing with this. Okay, we can argue with it, but there's really no arguing with it.
Yes, there is.
But anybody who says, right, any politician that says we're going to make gas cost what it really should cost, we're going to abolish the subsidies for gas and make, petrol cost what it costs in Europe at $6, $8 a gallon, is never going to get elected, right? So we're all worried about the short-term business, and no one wants to think long. You have to make some sacrifices. This is not, everyone can't win all of the time, right? Something's got to give. Someone's got to pay for the healthcare. Either we can say we don't care. I mean, in India, that's kind of what happens. There's no government healthcare. If you can afford it, you get treated. If you can't afford it, you die. Right? I mean, that's the way it is. There's no arguing with it. That's just the system that's there. Right? So if you say we want affordable healthcare for everyone, then everyone's got to make some sacrifices, because not everyone's going to have a job. Not everyone's going to be able to afford it. So what do we do as a society? Are we going to say, fine, we're going to pick up the slack for them, or are we going to say, tough shit, die?
Let me say two things about education. Number one, there have been many studies of, if you compare different people, what affects their health, which is usually we do it in life expectancy, because we can measure, we have good statistics on death. We don't have it on morbidity or illnesses. So that's why I keep talking about mortality, because the data is fine. And you can say, well, is it income? Is it race? Is it all sorts of other things? And it turns out the single most important factor is the level of education. So it's not education that you learn how to get a colonoscopy, it's level of education. So one reason you're healthy is because you're students. Big effect. So that's nice. The second thing I want to say about education is that I believe that the best university systems in the world is the United States. And the best in the United States, of course, the University of California. So that makes it the best in the world. And there's lots of that, meaning U.S. higher education dominates the world. There's no federal regulation of higher education. There are federal subsidies and financial aid and the like, but we do not have a national higher education system. We do not have one law which specifies what each student has to learn, how many years he has to be, what the admission standards are, what the prices are, nothing of that. And one possibility why the U.S. education system is so good, leave aside the private colleges who are incredibly wealthy, is because different states have experimented and done different things. And we don't know what the answer is for excellent education, so states adopt different ways, like California has a 3-tier system, Community College State, Cal State, and the University of California, and that works. And therefore, if we think of health, which is a far bigger part of the economy than higher education, perhaps what we should have done, rather than saying is we know the answer and this is the law, is encourage states to innovate and experiment, which did happen in Massachusetts, and we have some data. Wait 10, 20 years to see what works, and then either the states would adopt it on their own, or then we would know what happened, and maybe we could have federal law. But the idea that we know in a country of 300 million people how to reform a sixth of the economy without data, without experience, doesn't seem to fit our successes in other areas of policy.
But you mentioned Massachusetts. Mitt Romney started the Affordable Care Act, a version of it, in Massachusetts, and it's working.
Fair. It's a success, not a great
It is a
success.
success story. Massachusetts, what Mitt Romney did in Massachusetts, that's why I don't understand. When we talk about polarities and fragmentation in our government, I don't understand why Republicans are so against the Affordable Care Act. Because Mitt Romney did the exact same
he did for Obamacare. It was-
He did Obamacare. He implemented Obamacare in Massachusetts.
It should actually technically be called Mitt Romney.
Yeah.
So we have to be careful how we look at that. Number one, Massachusetts has the best education in the country, by any measure. Number two, it's a rich state. Number three, I believe the fraction of the population that was uninsured was 5%. Number four, it's not an unmitigated success. I've tried to look for data on health outcomes, and I just haven't seen any studies. It could be that I don't have to search, but I haven't found it. Costs have increased, and Massachusetts has now revised it in order to cap the increase in costs. But the single most important thing, if you just look at Massachusetts, has to do with access to care. Now, Massachusetts, when the Obamacare first came into effect, the average waiting time for getting an appointment increased dramatically. I think it was something like 3 months. Eventually, it declined. But if you adopt Obamacare in one state, then physicians, nurses, they can move into Massachusetts and therefore increase the supply, and therefore you can serve the additional demand. But if you do it for the United States all at once, you can't have people move from one state to another to increase total supply because we're still in the United States. So what will work for a small state, highly educated, wealthy, with low rate of people who are uninsured, and supply can increase in the state by moving from other states, that we can't immediately say that that's true for the United States as a whole. What we need is other states to experiment, like California. California is huge, and if something works in California, we have added confidence that it would work nationwide.
There was a comment. Yeah. Okay, and then there was like.
Yeah. So my question about jobs really was kind of like, well, we should buy American, and I do agree with that. But there's also part of it where I think you have to work 40 hours a week in order to basically charge cover your health, cover your insurance. Well, basically what this is more encouraging, what I'm seeing is why not just hire everyone at 39 hours? So then everyone, basically a lot of kids, well, basically us, would be more likely to get basically 39 hours a week, because then your business doesn't have to help cover the insurance as much anymore. So what they're looking at, the big strategy is, okay, we all have 3 part-time jobs, but we also still pay for insurance. Then we have our loans too. Then we have our cars. And then so how much is happening now? Is that going to help us at stress levels? Like as we know, stress is a pretty bad thing on health, and so now we don't have. I know everyone would say, well, yeah, we might have this, but that's a serious problem. Like we're a generation where that might happen to us, where it's going to be more difficult for not us, other people to get a real job that people.
So in Massachusetts, they didn't find that to be the case. They didn't find any significant decrease in the number of full-time employees once Obamacare went into effect over there. So yes, there is that argument that we'll start cutting everyone's hours to 39 hours a week. But also keep in mind, there's something to be said about corporate interests in wanting the best people to work for them. So if you're one of the best people and they say, we're going to cut you to 39 hours, you're going to say, all right, I'll hire someone who can't do the job as well, right? So it's always going to be a dynamic balance when we talk about hiring. And I think honestly we don't, and I agree with some of the sentiments that have been echoed, that we don't know all of the effects that it's going to have, but what we do know is we need to be doing something, right? And that's sort of what this is about. Is I'm happy about the affordable health care because at least it's sort of brought the problem back into the national spotlight, and we're now invested in getting some changes done. What that's going to look like, we don't know. I do want to also point out in terms of cost, though, another big thing about Obamacare, which I really like, is that it lays down specific guidelines about where the money that we're spending is going to go. So it says specifically that 80% has to go to patient care, and only 20% can go to administrative costs, which I think is another huge benefit because the one thing that I believe many studies have shown is that federal or government-run health insurance or healthcare providers actually have less overhead and less administrative costs than the private insurance companies.
Can I address that?
So, sure.
Number one, yes, Medicare has lower administrative costs. So Medicare is government healthcare paid for the elderly over 65. It has lower administrative costs than Blue Cross, Blue Anthem, the like. But it appears it's because they don't control fraud. So if you think it doesn't matter if there's fraud, then spend no money on administration, and your cost ratio is very low, and things are wonderful, except you have massive fraud, which we do have. So we shouldn't just look at how much is spent on administration, but what's done with it. The second thing, for medical care, think not levels, but think growth. So roughly, it's declined recently, but over the last 20 years or so, medical care spending in the country increases by about 5% a year. Some years it's been more. Now, if we suppose that we eliminated all profits, all administrative costs from all insurance companies. Now, insurance companies it's about half of all medical care spending is from insurance companies, so the 20% is 10% of total healthcare spending. That means after we eliminated all administrative expenses, all profits of health insurance companies, after 2 years, because the 5% growth, 2 times 5 is 10, after 2 years, we're back where we were before. And the Affordable Care Act does talk, and the administration has talked about the bending the curve, reducing the increase in costs. But if you think, what are we going to do about the high cost of medical care, we must think of how do we reduce the growth of medical care, not any one-time change.
Education.
Question.
You know, incident on this plea for education, which all of us believe in, to relate to the observation of how terrible our politicians are. So here we are in an educational environment. Now, I don't want anybody to speak up, but during election time, how many of you, assuming any of you, were inclined to vote for Romney, felt comfortable telling other people that, as compared to how many of you who were inclined to vote Obama felt comfortable telling other people that? I think there's a big difference. Let me get on an oath. Most of you, a large number of you before raise your hands that you were in biological sciences or pharmacological sciences. I'm sure a number of you who have those majors are also very active in your own churches. And I'm sure a number of you live in a religious world where you don't believe in Darwin's theory of evolution, where in fact you think it's wrong. And you live in a university world where you know that if you say that, your faculty member will downgrade you and consider you an idiot. Do you express that? Does the freedom of expression, so characteristic of the educational environment, allow you to express that? No way. So we are very complacent about how open-minded we are. We're open-minded towards people who agree with us in exactly the same way as the Tea Party supporters are. So part of your answer, what we need to do is to work in our own environment. So that diversity applies also to opinions and ways of looking at the world. Because the university world over time has become increasingly non-diverse. To give you one simple example, in the United States electorate, there's an approximate, somewhere close to a 50-50 split between Republicans and Democrats. Among university professors in all public and private institutions, the data indicate that 80% are Democrats and 5% are Republicans. Wow. That, if I weren't in the university, I wouldn't think that was such an open environment. So I think before we viciously criticize the politicians, we've got to figure out what can we do with our own environment. You, who voted for and worked for Obama, how many of your friends told you, how can you work for him? Romney's the guy. The person who felt that way felt they didn't have the freedom to express that view. Ours is a very constraining environment, very polarized environment, where a minority is not given the right to speak.
So
that is a problem.
I was just going to say, thank you everyone for final question. So, the purpose of the event was to show that we should have like an interdisciplinary understanding of the Affordable Care Act because it doesn't just affect one field, it affects a lot of fields. So, just like to ask you all, if you believe so, why do you believe that an interdisciplinary analysis of the Affordable Care Act is important? And then if you guys have any other questions at the end, feel free to come up to the professors and address them.
So I'd say this debate gave us a great insight into why you need to have an interdisciplinary approach to healthcare, right? I mean, we've talked about economics, we've talked about politics, we've talked about education, and I make jokes. So, you need all this. But seriously, I mean, it's such a complex problem. You can't talk about healthcare without understanding the etiology of the largest disease bases. What is it that's causing most of our spending in healthcare? What is that cause? How can we prevent it? How can we bend the curve as Obamacare, Affordable Health Care Act wants to do? You can't understand it without understanding the economics that drives the Affordable Health Care Act. Where's the money coming from? Where is it going? Some of the great studies that were pointed out. What are we going to do once we have all this money to spend on healthcare? So I think it's such a complex issue that you can't look at it with one lens, and you need to have a lot of these approaches to sort of get a better handle on where we're going, what we want to do.
I agree with everything that you said, and I'd like to add that we need to have more panels like this, and we need to have more educational programs like this. But let me just ask, how many, we were just, Pavel and I were talking about it, how many students do we have at UCI? How many undergrads do we have? 20,000, and how many do we have in this room? Less than 100.
So good, because I mean, this room would have held 25,000.
But I guess the point that I'm trying to make is that we need to have the interdisciplinary discussions and agreements and disagreements, but you guys have to start getting more and more interested. Just to answer your question, because if we have interdisciplinary approach, of course you want to have the Democrats and the Republicans included. I'm not a Republican and I'm not a Democrat. I'm very issue-based. And I feel very safe to express my ideas and opinions, even in a meeting or a gathering where most of my colleagues, let's say, are hardcore Democrats or hardcore Republicans. So I think it starts with you. And we each have to, again, educate ourselves to become that way. Because you have to vote, you have to get involved, and for those of you who were here tonight, now you're responsible to talk to other students, to talk to your friends, your roommates, your classmates, and really share the ideas that were presented here, because I learned a lot. I mean, if I had stayed home tonight and have not accepted Nikki's invitation, I wouldn't have learned, what I learned.
So you have a choice. You can either have interdisciplinary, or you can listen to economists. And of course, the correct answer, you should listen to economists. And there are two reasons. One, a huge part of the issue is economics. So insurance is economics. That's what economists study. That's with money. Incentives for health providers, fraud, all of that has to do with economics. So that's one reason, that the issue are the types of things that economists do. But the other reason, and I think perhaps even more important, is economists have a set of statistical methods which allow us to tease out from the data what is happening. So we don't deal with anecdotes and we don't deal with case studies. We look as broad a set of data as we can. And sometimes we design experiments, as happened with the Grant Health Insurance experiment. Sometimes we take advantage of something that happened in the world, as happened with the Oregon lottery. Sometimes we do across people. And in particular, you have to be very careful about what's called self-selection. Let me give an example. Hospitals, if you look at the data, hospitals cause people to die. Don't go to a hospital. More people die in a hospital than anywhere else. Well, of course that's true, but we know why, because sick people go to hospitals. Similarly, if you're doing health insurance, you have to worry who chooses to buy health insurance. If you're dealing with employment, whether firms reduce employment, you have to ask, well, why did they not offer insurance in the first place? So you have to be very attentive to why people are behaving differently. And only after you explicitly consider why people are behaving, like Why is this person in the hospital? Only then can you figure out what is happening.
I totally agree with my folks.
We're so consensual.
Finally.
I did want, however, there's one of you in the back row who had not asked the question and had raised your hand. And I'd love you to ask your question because there was a small subgroup who had a lot of questions.
And then one of the articles I read by Time Magazine was called The Bitter Pill. I don't know if you read that. The Bitter Pill. So one of the reasons why healthcare is so high is because these price masters who set up these costs that don't even meet market value. So I know that Dr. Jafari addressed that there's more transparency in that, but other than that, is there anything else to address that? It's like disparity and inflation of healthcare costs.
Not in the Affordable Health Care Act, I don't think.
No, not in ACA, but I think what we see is a good start. We didn't have that. The
So
transparency
did everyone
is very new.
hear her question?
Yeah.
Barely? So everyone got it, we don't need to repeat the question.
No, you
Excuse me,
read.
oh, I, so her question was, one of the issues we brought about, and so there's really great research article called The Bitter Pill that came out, it was a couple of months ago, 6 months ago, so. Oh, a year ago, that far back, okay. In time, and he was essentially, one of the issues that this article brought up was that one of the reasons why we spend so much money on healthcare is because of this lack of transparency in what a simple procedure costs, or what any procedure costs. And so that was what Dr. Jafari was saying, is that one of the things is that now it's becoming more transparent, so you can compare costs across providers and say, okay, I need an MRI, I need a CAT scan, I need a colonoscopy, UCI is going to charge me $15,000, and Hogue is going to charge me $900, or is it the other way around? Whichever way. It goes, and so either way they stick it to you for a colonoscopy. So does the Healthcare Act do anything to address this, or what are we doing to sort of change this? And if we have more transparency, can we drive some healthcare costs down? And the answer is the economists will weigh in and tell us if that's true or not. But I have to imagine it will have some effect if there's more transparency in these costs. But the Affordable Healthcare Act itself has no provisions that deal with that particular aspect of healthcare.
So I have health insurance, and under the Affordable Care Act, health insurance, you may be responsible for the first or part of the first $7,500 expenses, but nothing after that. So the insurance company has to pay all of your expenses following $7,500. The big cost in medical care in hospitals where it's $10,000 a day easily. But that means if I'm fully covered for my expenses for hospitalization, that's big money, I don't care how much it costs, I don't pay any of it. So if I know that it's costs up to $100,000 and another hospital is $200,000, I don't care because I don't pay it. So for the big costs, the major costs in healthcare, I don't think transparent. So, but the Affordable Care Act does deal with some of that. There is a
That means it's probably 80%.
The Affordable Care Act has a provision that if employers provide insurance policies which cost the employer more than, I think it's about $25,000, then there is a tax on the employer. That means that employers have an incentive not to provide very generous health insurance. And that means that individuals have a greater incentive to care about how much they spend. So first, we have to give individuals some incentive to spend less money. And second, once we have that, then we increase transparency. Once the consumer knows how much it will cost, the consumers may choose to spend less money.
So, okay, thank you all for coming. We really I hope that you gained something out of this event and enjoyed it as much as I did. And if the professors are available to maybe stick around at the end, if you have any specific questions, feel free to go up to them. And so thank you all for coming. And if you could just join me in giving a round of applause. Thank you.
You're really curious about it.
Thanks for coming. How you doing?